do you want to know the difference between ulcerative colitis and Crohn's disease? Then keep watching. As mentioned before, today we're going to talk about Crohn's versus ulcerative colitis. There's a lot of similarities, but then there's also distinct differences, and it is easy to get them confused. So from now on, I'm just going to say UC to make it easier for ulcerative colitis. But both UC and Crohn's are inflammatory bowel diseases, not to be confused with irritable bowel disease. Very different, okay? This is an autoimmune condition. Inflammation, inflammatory, autoimmune, okay? Think of your M's. So both of them are inflammatory bowel diseases, and it results because there's chronic inflammation of the intestine with periods of remission and exacerbation. And the cause of these conditions is multifactorial. Some individuals are predisposed, so there's a genetic component. It can be environmental triggers, stress. So that's why we say multifactorial. Dysregulated immune response of intestinal mucosa to microbes in the genetically susceptible. Basically, the intestine is attacking itself. Again, so with inflammatory bowel disease, it's an autoimmune disease. Some antigen triggers an overactive and sustained inflammatory response. And that's why it's so painful, because their intestines are inflamed. It's genetic and environmental factors, again, multifactorial or polygenetic. It usually develops in teenage to early adult years. There's a second peak in the 60s, and it's very prevalent in industrialized regions and among Caucasians and Jewish descendants. And they're not really sure why it's prevalent in industrialized nations. Now let's get to the differences. With Crohn's disease, what you need to know, it can be anywhere from the mouth to the anus, okay? Anywhere in the GI tract, mouth to anus. It's most commonly in the terminal ileum. Crohn's has skip lesions. That means that there's healthy tissue between the areas of inflammation, whereas UC is continuous inflammation only in the colon or the large intestine. The inflammation is also transmural. It is the entire thickness of the bowel wall, whereas UC is more superficial. Ulcerations are deep and they have a cobblestone appearance. Complications from Crohn's, they can have fistulas between the bowel and vagina, bladder, or outside of the body. They can get stricture or obstruction, perforation. It can reoccur after surgical intervention. Sometimes they do have to, if it's severe, they have to resect a part of the intestine, but it doesn't cure it. It can come back. They also have an increased risk of small bowel and colon cancer, though that it's less than UC. So that's important too, that they have a risk for cancer, colon cancer and small bowel. And smoking increases the risk for this disease. So for Crohn's, if you smoke, increased risk. With UC, it's only the large intestine, okay? So the large intestine, the colon, remember the colon is part of, we have the ascending, transverse, and descending. So it only happens there. It starts in and about 95% of the time, it's usually in the rectum or the anus. So it starts in the rectum and it spreads in a continuous pattern. Remember, Crohn's was not continuous. UC is continuous. In a continuous pattern up the colon, there are no skip lesions. And it only involves the mucosa and submucosa, so it's not as deep and there's not that cobblestoning. And rarely will there be small bowel involvement. Complications of UC, occasional stricture obstruction, toxic megacolon, perforation of that, pseudopolyps, and colon cancer risk after 10 years of disease. Now with UC, it can be cured with a colectomy. So if they take out that part of the bowel, technically they are cured and it won't reoccur. Whereas with Crohn's, they are not cured ever. Risk may increase after smoking cessation. So for reasons that they're not really sure, with UC, smoking actually has a protective factor against UC. With Crohn's, they are going to have diarrhea, abdominal pain, fever, weight loss, and it may be severe due to malabsorption. Rectal bleeding is infrequent with Crohn's, and they are going to have malabsorption and nutritional deficiencies. Notice how here it says infrequent. It may happen, but it's infrequent. And remember, I'm teaching you for textbook world. So in textbook world, when you're trying to differentiate between Crohn's and UC, rectal bleeding is infrequent. Whereas we go to ulcerative colitis, their rectal bleeding is common. Remember that I said that usually the involvement in UC is rectal or the anus. So with UC, they can have diarrhea, abdominal pain, fever during an acute attack. Rectal bleeding is common, severe weight loss and dehydration, and proctitis and tenesmus. Tenesmus is basically a sensation of like they just went to the bathroom and they feel like they have to go again. And proctitis is inflammation of the rectal area and the anus. This is a way of bringing it all together. Ulcerative colitis versus Crohn's disease. Notice how it says that UC affects the entire large intestine. Here we have our large intestine, right? It can affect the entire colon. They can have loss of the haustra or that rugae. They can have pseudopolyps and damage to the mucosal lining. With Crohn's disease, it can affect any part of the digestive tract from the mouth to the anus. Notice they can have ulcers in various parts of the body. And I have another picture to help you. Here again, we have ulcerative colitis versus Crohn's. Notice again here, here's our stomach, we have small intestine, and this is our colon. Ascending, transverse, descending. The red area is the inflamed portion. Notice again in UC that only the colon is involved and it's continuous. In Crohn's, look, we have inflammation in the ascending, in the ileum, which is part of the small intestine, right? The small intestine is unaffected in UC. We have skip lesions, right? Look, it's healthy, 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 lesion here. So we have a lesion in the ascending, transverse, and the descending. But look, it's skipped here. This is healthy bowel. So once again, with Crohn's, you have these skips. UC is continuous. And notice how the rectum is involved in UC and the rectum is not involved here. Now, occasionally the rectum can be involved in Crohn's, but typically the rectum is involved in UC. Let's put it all together. A client who has had ulcerative colitis for the past 5 years is admitted to the hospital with an exacerbation of the disease. Which of the following factors was most likely of greatest significance in causing an exacerbation of UC? Is it a demanding and stressful job, changing to a vegetarian diet, beginning a weightlifting program, or walking 2 miles every day? And the answer is going to be stress. So stress, emotional events have been clearly linked to exacerbations of UC. Now, although they don't cause it, but they can make it worse. A modified vegetarian diet is not likely to cause an exacerbation. So that's an important point also, that stress will not cause UC, but it will make it worse. So once you have it, you want to avoid stress. Which of the following diets would be most appropriate for the client with UC? Are we going to give them a high calorie, low protein, low residue, low fat, high fiber, low sodium, high carbohydrate? Let's think a little bit, right? Their colon is inflamed, and they may be losing weight. So we want to maximize, we want to give them more bang for their buck. Also remember that our bodies cannot digest fiber. So if something is already inflamed, do we really want to put lots of roughage, as we call it, or residue in there that it can get stuck in the pockets, in our little pouches in the intestine? No, not really. So the answer is going to be, what do you think? Is high protein, low residue. We don't want anything to get stuck in there. Clients with UC should follow a well-balanced, high protein, high calorie, low residue diet. And they want to avoid high residue foods such as whole wheat, nuts, raw fruits, and vegetables. They need more protein for tissue healing, and they should avoid excess roughage. They love to ask about fluid and electrolytes on the NCLEX. A client who has a history of Crohn's disease is admitted to the hospital with fever, diarrhea, cramping, abdominal pain, and weight loss. the nurse should monitor the client for hyperalbuminemia, thrombocytopenia, hypokalemia, hypercalcemia. Think about priorities, right? Which electrolyte is absolutely essential? Which electrolyte abnormality could really affect someone's health? So when you're reading that, remember what is the most significant one? Which is the most significant electrolyte? Or they give us two electrolytes and the other ones aren't really electrolytes. So thrombocytopenia is a deficiency in platelets or too much albumin, right? So remember, what would be the most important or significant? The answer is going to be hypokalemia. It's the most expected laboratory finding owing to diarrhea. So if someone's having diarrhea, as is common with Crohn's, they're likely to have hypokalemia. They're losing that through their diarrhea, through their feces. Hypoalbuminemia can occur in Crohn's. But again, what is the greatest importance? It's the potassium level, because if your potassium level is too low, you can have cardiac arrest. Okay, a lot of times on NCLEX questions, think carefully because a lot of times it's going to be potassium. Potassium will usually be the answer. All right, and to conclude, thank you so much for watching. This is a funny meme of the week. Listening to report for the first time as a nursing student, and it's like, can you repeat the part of the stuff where you said all about the things? When you're first getting a report, when you're fresh out of school, or when you're even just doing practicum, it can be a little bit overwhelming and you're trying to write everything down and you're missing a whole bunch of stuff. Thank you so much for watching. Have a great day. Mwah.